Hi, everyone. My name is Claire Jaquia, and I am a communications major here at George Fox University. And today I am going to be talking to you all about intermittent explosive disorder. So let's dive right in. First off, what is intermittent explosive disorder? For the purposes of this presentation, I will be referring to intermittent explosive disorder as IED as well. So what is intermittent explosive disorder? Intermittent explosive disorder is considered a psychiatric disorder. It is distinguished by a continued acts of aggression and includes a failure to control aggressive outbursts. People with IED have a difficult time regulating their emotions. Also, a little bit of history and context for you guys. The IED was first seen in 1980 in the DSM-3. So now on to some contributors as well as some comorbidity of IED. So some of the contributors that I found when researching IED was adverse childhoods as well as childhood abuse. So adverse childhoods included just difficulties all around during their childhood, maybe some poverty or some parents in and out. And then childhood abuse includes physical and emotional. Uh, with adverse and abuse, the child basically had a need and a want to protect themselves. And so this protection caused them to have either verbal or physical outbursts of aggression towards those around them. So parents, kids, teachers, caregivers, all of those. And then with IED, as I was researching it, I found a lot of comorbidity with it. And so some of the comorbidity that I found in my research was attention deficit hyperactivity disorder, alcohol use disorders, anxiety disorders, depressive disorders, post-traumatic stress disorder, bipolar disorder, substance use, borderline personality disorder, and antisocial disorder. So with all of this research, I found, and the researchers found that people with IED were at the more extreme end of the spectrum with these disorders. They had a lot more of the aggressive tendencies that came out with these disorders because IED includes a lot of aggressive tendencies. So one of the reasons that alcohol use disorders and substance use disorders were seen with IED is because they tried to escape the need to be aggressive and to also escape their childhood trauma. And then also in tying in with that, with the comorbidity of post-traumatic stress disorder came from their adverse childhoods as well as their childhood abuse that they experienced, whether being physical or emotional. And then in terms of borderline personality disorder and bipolar disorder, a lot of mood swings and aggressive tendencies are seen in these disorders. So that also makes sense that the comorbidity of IED comes in play with those disorders as well. So now on to some ethics. The two ethics that I focused most on after looking everything up was diagnosing children as well as abuse. So in terms of diagnosing children in the psychiatric world as a whole, there's a large question around how young can a child be to be accurately diagnosed. And since with IED, a child can be diagnosed as young as the age of 6, that question comes into play with IED as well. So whether or not this child is just going through some difficult behavioral issues or if they are experiencing a rough time in their childhood or if they actually do need to be diagnosed with IED. That's a big question. And then also with ethics comes the topic around abuse, which I've already touched on quite a bit, but abuse of the child specifically when they're growing up, and then also after they have their diagnosis of being abused because they have IED or because they are continuing to have these outbursts and not being a good child and all those things. That's an ethical concern, but also an ethical concern around if these children are safe enough and if these people are safe enough to be around others. It's a concern as a child starts growing up and gets bigger and starts having these aggressive outbursts towards parents and caregivers and teachers and even other children around them, this can be dangerous for those interacting with these children or young adults or however old they are. So that's a little bit of an ethical concern there. And then in terms of some changes that came around with IED, the DSM-5 now includes both verbal and physical aggression as a way to diagnose IED. So the DSM-4 originally only included the physical aggression as a way of being diagnosed, but now it includes both verbal and physical, which is a pretty big change. Because some of these children or some of these people do not act out aggressively in a physical aggressive way. They don't have those outbursts. They only have outbursts in a verbal way. So now they can both be classified. And now moving on to some IED population. The one population that IED became more prevalent in was juvenile and adult criminals, which makes sense. Most juvenile and adult criminals have some child abuse. And as I have said previously, child abuse therefore leads typically to a more likely diagnosis of IED. And then another thing that I noticed surrounding IED was the lack of research on children. The past 5 to 6 years when I was doing my research on that time period, there was a lack of research specifically on children that were around that age of 6 when they were first being diagnosed at that young age, which I found very interesting and an area that researchers should probably focus more on. So now onto some treatments. So there is no 100% effective treatment that has been found for IED. But one treatment that has shown a lot of promise is cognitive behavioral therapy. And that's shown some very positive effects. And then in terms of, since there is no 100% effective treatment, most are trying to find new alternative treatments for IED. So carbamazepine is a drug that they have just started researching back in 2018. And they noticed some really positive results with after just a couple months of some of these patients taking this drug. They had a really positive outcome with a decrease in how many episodes they were having per month of their aggressive outbursts. So that was a really positive thing that was seen. And then another alternative treatment that was being looked at back in 2016 was video cognitive behavioral therapy. So a group of researchers were curious if these people with IED were able to get the same benefit from a cognitive behavioral treatment in a video conferencing setting versus in person. And they actually saw some really positive effects with this as well, which is really promising, especially for right now being in a global pandemic, that those with IED can still get a good amount of therapy and still have those resources at their fingertips, even in a worldwide pandemic. So I found that really interesting too, that that research was done back in 2016, but is helping so much now in 2021. So now, looking forward to Thursday, I need you guys. We need you, me and my friend who is a teacher. We need you to become our clinicians, and we need your help because this teacher is experiencing a child in her classroom with IED. And so you guys are going to become the clinicians for a day and give us some feedback. So I look forward to getting to have you guys touch base with that and hear some of your responses. So thank you so much for listening to me. And I hope that you guys see how IED can affect so many around besides just the person with it. And I'm going to pop over and show you my references. And I hope you all have an amazing day. Thank you.